Atrial fibrillation ablation, does mapping strategy influence outcomes? We all know from an early study by Dr. Hassegaer and the Bordeaux group a number of years ago and published in New England Journal that the triggers for atrial fibrillation come from the pulmonary veins, primarily from the pulmonary veins. From the initial work by Dr. Hassegaer, initially we mapped these triggers deep within the pulmonary veins, and it was a somewhat laborious process. You had to actually have the patient going in and out of atrial fibrillation and map the triggers just like you would map any atrial tachycardia. Frequently this involved burning deep within the vein and led to pulmonary vein stenosis, and in addition, again, it was a laborious process and had frequent recurrences, again, because not all the triggers are seen at every procedure and for a lot of other reasons. This quickly evolved into an anatomic sort of procedure where the vein itself was isolated such that lesions were created around the ostium of the pulmonary veins so that even if the triggers were firing within the pulmonary veins, they couldn't escape to the atrium and cause atrial fibrillation. Well, initially, all this isolation was performed with a circular mapping catheter, and the mapping involved looking at these pulmonary vein potentials, and the idea is to ablate around the vein with the elimination of those potentials. When the potentials are eliminated, when the sharp potentials are eliminated, that's called entrance block into the vein. Another endpoint of mapping and ablation of the pulmonary veins is exit block, where the same circular mapping catheter is used. There's electrodes on the catheter. You can pace at each electrode pair, and if you cannot capture the atrium with pacing at any of these electrode pairs, it's called exit block. The circular mapping catheter is typically placed in the os or a little bit into the pulmonary vein for this mapping and ablation. Well, the procedure initially was either circumferential or segmental isolation and ablation of the vein at a very ostial or right at the os of the pulmonary vein where it enters the atrium. This led, however, to some pulmonary vein stenosis and some other issues, so it quickly segued into a more antral ablation strategy where the lesions were placed further out from the pulmonary veins, again, either in a circumferential pattern encompassing both veins on one side, or segmental where the superior and the inferior veins were isolated separately. The other thing that was sort of quickly learned is that if you did not check for isolation, if you just did ablation, just made dots around the veins without checking for electrical isolation, there was a very high chance for recurrence. So actually isolating the veins and checking for that isolation with any sort of mapping was important. The same held true for creating any lines of block. You have to check for isolation, and we'll return to that topic. What else can you map when ablating atrial fibrillation? Well, it's known that at least 15% of patients have non-pulmonary vein triggers for atrial fibrillation. These triggers can come from anywhere in either atrium, but come from very typical spots, including the septal area, the posterior wall, the left atrium, along the crista, in the either atrial appendage, eustachian ridge. Basically, any place that you typically find atrial tachycardias, you find these triggers. In addition to patients having both pulmonary vein and non-pulmonary vein triggers for atrial fibrillation, it's important to note that in one study that the Penn group did a number of years ago, 2.3% of patients had just non-pulmonary vein triggers for atrial fibrillation. So if you're not thinking about non-pulmonary vein triggers and looking for non-pulmonary vein triggers and mapping and ablating non-pulmonary vein triggers, you may be ablating pulmonary veins and not even treating the actual cause of atrial fibrillation in a small group of patients. In addition to pulmonary veins and non-pulmonary vein triggers, there's a lot of work being done on mapping and ablating complex fractionated electrograms, or CAFEs, as they're commonly called. A CAFE is, again, a complex fractionated electrogram, which is mapped by the various electroanatomic mapping systems. They're displayed in color on this system as the red and white areas, and these are areas of very short cycle length. I think in this paper was less than 120 millisecond signals that are very fractionated, look very disorganized. You can also, in the purple areas, it's a greater cycle length, greater than 120 milliseconds, and actually look much more organized. Even though it's still atrial fibrillation, it's a much more organized signal. In any event, you can ablate in these red and white areas to get rid of the complex fractionated electrograms. And in this initial study by Dr. Nanamani from 2004, he ablated just the CAFEs and had a reasonable success rate. He thought that the CAFEs correlated to areas of slowed conduction and possibly the pivot points of the various reentrant wavelets that create atrial fibrillation. And he found that although they can occur anywhere in the atria, just like non-pulmonary vein triggers, they come from very typical sites, including around the pulmonary veins, around the CS os and the mitral valve annulus, the septum between the right and left atrium, and the roof of the posterior left atrium. So there's still, again, a lot of work being done into CAFEs. There's debates going on about what they actually represent. Are they trigger sites? Are they AFib drivers? Are they indeed the collision of wavefronts? Are they just passively activated and therefore unimportant? Are they overlying ganglionic plexi? And are they an important target for ablation? Again, all of this is being worked out. In addition to the non-pulmonary vein and pulmonary vein triggers and CAFEs, many groups do lines in at least certain subsets of patients. These lines, again, need to be mapped in order to ablate. In this early paper by Dr. Sanders, and that's the Dr. Hasegair group once again, they were actually trying to compartmentalize the left atrium by drawing a roof and a roof line between the two superior veins and an anterior line from the right superior pulmonary vein to the mitral annulus. Other lines that can be made include the left inferior pulmonary vein to the mitral annulus, which frequently requires lesions within the coronary sinus in order to create block. You sometimes see lines from the right inferior to the mitral annulus, isolation of the superior vena cava, of course the typical right atrial cavo-tricuspid isthmus line, and all sorts of other lines, including a box set around all four veins, lesions along the whole length of the CS, and again other lines. The goal in a lot of the papers was to find a sort of anatomic way to ablate atrial fibrillation that would be able to be reproduced and done without actual thought into the reasons for atrial fibrillation. However, what we found with a lot of the problems with lines is that if you don't make a complete line, or if the part of the line breaks down, it actually causes proarrhythmia, causes further arrhythmias such as mitral annular flutter and other left atrial tachycardias and flutters. This is because once you create slowed conduction, you actually create the propensity for more arrhythmias. So many of these lesions, many of these papers involved with just lines or lines plus pulmonary vein isolation has a high recurrence of left atrial flutters that then need to be ablated at a separate study. So what is the outcome with various types of procedures? What we do know is with pulmonary vein isolation, plus minus other lines or non-pulmonary vein triggers, the success rate is reasonable. These are just 3 studies that were randomized trials versus antiarrhythmic drugs that were used because the follow-up was good and standardized, but that, again, a very high percent of success in the range of 90%. In patients with long-lasting atrial fibrillation, however, in this very recent in-press article in Heart Rhythm that's going to be coming out this year by Dr. Brooks and his colleagues in Australia, they reviewed 30 plus papers of ablation in patients with long-lasting atrial fibrillation. These papers described numerous techniques and had various degrees of success, and condensing all of this information on this somewhat busy table into a few salient points. The single procedure success rate for any type of procedure in patients with long-lasting atrial fibrillation ranged from 21 to 68%, again a lot lower than those reported for paroxysmal atrial fibrillation. Repeat procedures and adjuvant use of antiarrhythmic drug therapies were very commonly needed, and for longer-term success and higher degrees of success, and that cafe ablation alone without pulmonary vein isolation wasn't very successful in the range of 30%. Other groups have not been able to reproduce Dr. Nanamani's initial success. What we also know about atrial fibrillation ablation is that if a patient has recurrent atrial fibrillation and requires repeat ablation, nearly all or all patients have at least one reconnected vein. So isolating the veins is important, and durable isolation is important. If you don't have durable isolation of at least some of the veins, then you have recurrent atrial fibrillation. In these groups, they also reported in patients even in their 3rd or 4th atrial fibrillation ablation procedures, all the patients still had some reconnected veins. So durable pulmonary vein isolation is probably very important. In addition, what we don't know is in patients that don't have atrial fibrillation, are there patients that have veins that are reconnected? And these 4 groups actually brought asymptomatic patients without atrial fibrillation back to the lab to check their veins. And these 2 groups, they found very low rates of reconnection. This group had nobody that had any, all the veins were still disconnected, and this had only a few patients with 1 or 2 reconnected veins. Yet these 2 groups had a high percentage of patients with reconnected veins. So the question comes up, is it possible to have reconnected veins and still not have atrial fibrillation? The difference in these 4 studies, there was many differences in these 4 studies that may account for the difference in the findings, including what their initial and follow-up criteria for isolation was, the amount of energy they delivered, and the time to the second study, as well as in some cases the presence of delay in the left atrial PV to the pulmonary vein. So delay. So the vein was reconnected, but there was delay into the pulmonary vein, and then different monitoring for asymptomatic AFib. So it's possible that in these 2 studies that they actually did have atrial fibrillation, it was just asymptomatic, and therefore they were studying the wrong group of patients. So overall, from all this information and other mapping and ablation information that we have already, what do we know? Well, we know that ablation in patients with paroxysmal atrial fibrillation is successful, but we need to work out how to prevent recurrences. The pulmonary veins are important. If what we need is better endpoints to durable pulmonary vein isolation. Right now we have entry and exit block, and it's trying to be worked out what else we need to know before pulling the catheters out. And various groups have tried various things, including isoproterenol or adenosine infusions. Checking the lines by mapping along the lines. Some places actually are testing by pacing along the lines, and various other endpoints. And again, all of these are looking for endpoints of durable pulmonary vein isolation. We do know if you make a line, it better be blocked, because if it's not blocked, you're likely to get atrial tachycardias and atrial flutters, which then will have to be ablated. The non-pulmonary, looking for and ablating non-pulmonary vein triggers may be very important, especially in certain subgroups of patients. We might need to do more, such as some sort of substrate modification, and whether this is cafes or lines or some other ablation, but you may need to do more in persistent atrial fibrillation, because it may not be just about the pulmonary veins and triggers. It may be about remodeling and the maintenance of atrial fibrillation, which may be different than the triggering of atrial fibrillation. And does mapping matter? Yes. You need to make sure, at the very least, that your pulmonary veins are isolated and that your lines are blocked.